Hope everyone's doing well. Good morning. Welcome to the August GI Journal Club, presenting here from Orlando, Florida. Our first study for the Journal Club is a randomized trial comparing immediate oral refeeding versus the conventional slow progressive oral refeeding in patients with mild and moderate acute pancreatitis, published by Ramirez Maldonado et al. In the Annals of Surgery. The study is important because the timing of initiation of oral diet in acute pancreatitis does remain controversial. The current guidelines in patients with mild to moderate acute pancreatitis advocate early oral feeding, which means that oral feeding to be commenced when the pain has resolved and lab parameters have improved. And this commonly translates to fasting during the first 24 to 48 hours after admission, followed by gradual advancement of oral intake over 5 to 7 days. However, prolonged fasting in acute pancreatitis may induce intestinal atrophy, loss of epithelial barrier function, changes to intestinal flora, which can all contribute to the development of systemic inflammatory response syndrome, increased risk of sepsis and organ failure in these patients. The aim of this randomized trial was therefore to compare immediate oral feeding versus conventional oral feeding in patients with mild to moderate acute pancreatitis. This was a randomized trial conducted in 4 centers in Spain. They included only patients with mild to moderate acute pancreatitis. Patients were randomized in a 1-to-1 ratio into 2 groups, either immediate oral feeding, which meant that immediately upon admission to the hospital, solid low-fat diet was started, regardless of patient symptoms or lab parameters. And the other group was controlled oral feeding, which is a gradual advancement of diet with fasting initially, followed by clear liquids, and then low-fat solid diet only when there was absence of abdominal pain, white cell count was less than 15, and there was a drop in CRP. Follow-up was conducted at 1 to 3 months post-discharge, and the primary outcome measure was the length of hospitalization. So as you can see, between the 2 groups, there was no significant difference in baseline characteristics. The ASA classes were 3 and 4 in about 21% of the study population. Leukocyte levels were 9.4 in the immediate feeding group, 9.2 in the controlled feeding group, and CIS is present in total of 7.6% of the study cohort. 71 patients were randomized to the immediate feeding and 60 patients to the controlled refeeding groups. These are the outcome measures. If you look on the first row, the primary outcome of length of hospital stay was significantly shorter for the immediate feeding group at 3.4 days versus 8.8 days. Again, which I found to be a little surprising, to be honest with you, the need for opioids or analgesic infusion was significantly lower in the immediate refeeding group at 0 versus 8.3% in the controlled feeding group. Also, the intolerance to diet was actually much higher in the controlled refeeding group, which I also found surprising. The reason for intolerance to diet was relapse of pain in 16.7% of the controlled refeeding group. Progression of acute pancreatitis also worse for the controlled feeding group at 10% versus 0. And complication rates were also significantly high in the controlled feeding group at 18.3% versus 4%. The immediate feeding group also had no admissions to the ICU versus 6.6% in the controlled feeding group. And again, in the hospital readmission rate was also lower in the immediate refeeding group compared to the control feeding group, although this difference was not statistically significant. When they also compared costs in euros, they do not specify whether this was statistically significant or not. The total cost for the immediate refeeding group was significantly lower, almost half at 1,200 euros versus about 2,500 euros for the conventional refeeding group. They performed a log rank Kaplan-Meier curve analysis, and they again confirmed that the length of hospital stay is much shorter for the immediate refeeding group compared to the solid line here, which is the controlled feeding group. The limitations of this study is that there was no blinding at all, and therefore there is always potential for bias, although this is a randomized trial, and I feel like it's difficult to blind with this type of randomized trial. The follow-up period was very short, and there was a lack of detailed assessment of complications that arose in the patients in the study. So the main take-home point from this study is that immediate oral feeding with low-fat solid diet to patients immediately after admission basically reduced length of stay and hospital costs in patients with mild to moderate acute pancreatitis compared to conventional oral feeding method of gradual diet advancement. My next study was published in Gastroenterology by authors Rokers et al. This is a network meta-analysis comparing the effectiveness of multiple different first-line treatment regime for H. pylori infection. This study is important in our clinical practice because H. pylori infection is clinically important. It is now identified as the main cause of gastritis, peptic ulcer disease, MALT, gastric mucosa-associated lymphoid tissue lymphoma, MALT lymphoma, and gastric cancer. However, the overall treatment success of H. pylori eradication remains low, despite the availability of a wide variety of regimes. The aim of the study was to use meta-analysis to study the comparative effectiveness of all current first-line dual, triple, and quadruple therapies for H. pylori infection and rank all the available therapies in the order of effectiveness. So as mentioned before, this was a meta-analysis. They included all randomized trials comparing different regimes given as first-line therapy. They included only studies where the patients had more than 7 days of treatment, and the randomized trials that they included had at least 50 patients in each arm. So this meta-analysis included 68 randomized trials, and this comprised over 20,000 patients receiving one of the following 8 first-line treatment for H. pylori: high-dose amoxicillin dual therapy, the standard clarithromycin-based triple therapy, concomitant quadruple bismuth therapy, concomitant quadruple non-bismuth therapy, levofloxacin-containing therapy, reverse hybrid therapy, which is when you give protonics with amoxicillin for 12 days, and then clarithromycin and Vladol for initially also for 7 days. Sequential quadruple therapy, and vonoprozin-containing triple therapy. So this is a summary of the cure rates for the 8 different regimes. As you can see, only 2 regimes receive a cure rate of over 90% when you're looking at all the randomized trials as a whole, and that's the vonoprazan-based triple therapy and the reverse hybrid therapy. In the West, levofloxacin-based therapy achieved the highest eradication rates, and again in Eastern Asia, vonoprazan-based triple therapy and reverse hybrid therapy also achieved the highest rates. In Western Asia, the highest achieving treatment cure rate is the levofloxacin-based triple therapy. As you can see, the traditional clarithromycin-based triple therapy performed the worst out of all the regimes, and I think it's probably one of the most commonly used first-line therapies and the most traditionally used. And as you can see, it only achieved cure rates of about 75% overall. They also looked at the effectiveness of each regime by looking at the surface under the cumulative ranking curve, which essentially also just acted to look at the effectiveness of each of these therapies. And as you can see, the vonopressin-based triple therapy performed the best out of all, with area under the curve of more than 90% overall. This table is just a summary of one therapy being compared to another. So it's very busy, but it basically confirms the ranking that we saw before with the different cure rates, where the vonopressin triple therapy performs the best out of all. And as you can see, the effectiveness of vonopressin triple therapy is almost 4 times that of the traditional clarithromycin-based triple therapy. So what they also did was, again, just analyzed the effectiveness of the different H. pylori irradiation therapies in a slightly different way. And they compared vonopressin-based triple therapy and all the other 7 H. pylori eradication therapy to the clarithromycin-based triple therapy. And they just tried to see which one was most effective against triple therapy, basically. And as you can see, again, vonopressin-based triple therapy and reverse hybrid therapy are the most effective and are significantly more effective than the triple therapy, as was the non-bismuth quadruple therapy, levofloxacin-based therapy, sequential therapy, and bismuth-based quadruple therapy. Amoxicillin dual therapy was not significantly better than the triple therapy. The limitations of this meta-analysis is that the randomized trials included in the meta-analysis were not double-blinded and they were open-label, but I think this is a relatively minor limitation, considering they were able to include only randomized trials and recruit, which comprised over 20,000 patients in this meta-analysis. And only the regime efficacy was evaluated, with no analysis performed regarding the safety of these regimes and tolerance of these regimes by patients. And the resistance of H. pylori to these antibiotic regimes were not taken into account in this meta-analysis. So to summarize, this meta-analysis showed that vonopressin-based triple therapy and reverse hybrid therapy were the only therapy regime to achieve eradication rates of greater than 90%. And levofloxacin-based therapy achieved the highest eradication rates in Western countries. Vonopressin triple therapy was the best regime, and standard triple therapy was the least efficacious regime, but vonopressin-based therapy was tested only in Japan, and therefore further studies from various parts of the world are needed to confirm its high efficacy. Our next study is a multi-center randomized trial comparing 2 bowel cleansing regimes for colonoscopy after failed bowel prep. And the study is by Say et al. In Canada and published in Clinical Gastroenterology and Hepatology this year or this month. So this study is important in our clinical practice because failed bowel prep for colonoscopy is common. It's reported as up to 10% of cases, although I think in clinical practice, it feels like it's much higher. However, the best regime for subsequent attempt is not known. The aim of the study was to compare 2 different bowel prep regimes in achieving adequate bowel prep in patients with prior failure of bowel preparation. So this was a multi-center randomized trial based in Canada, involving 4 centers, and they were able to recruit 196 patients into the study. Now, adult patients who failed bowel prep at their index colonoscopy and required a repeat colonoscopy were screened and included in the study. The definition that they used for inadequate or failed bowel prep in this study was they used two different society definitions, or two definitions. One was a US multi-society task force definition, which means that the endoscopist is unable to exclude polyps greater than 5 millimeters. I think I meant to say less than 5 millimeters in size. They're unable to see polyps less than 5 millimeters in size and requiring shorter interval to next colonoscopy. The Boston Bowel Prep's scale score of more than 6. So the bowel prep regime used in the study, there were two regimes. They were both polyethylene glycol based. One was the traditional 4-liter polyethylene glycol based regime, but split dosed. That was preceded by bisacodyl taken before. So that regime was structured as such. Patients took the bisacodyl on the day before the procedure. Then they had 2 liters of polyethylene glycol at 8 to 10, 2 liters at between 8 to 10 p.m., and then 2 liters on the day of the procedure. The next regime basically comprised of a very high volume polyethylene glycol regime, where again patients took bisacodyl the day before the procedure, and then 4 liters of polyethylene glycol taken between 6 and 10 p.m., and then 2 liters on the day of the procedure about 4 to 6 hours before. All patients were asked to follow a low-fat diet 3 days prior to the procedure and had clear liquid diet on the day prior to the procedure. And the follow-up duration was relatively short at 14 days. So these were the outcome measures. The main takeaway from this table is that there is no difference between the traditional 4-liter versus the 6-liter polyethylene glycol bowel prep regime with the addition of bisacodyl. So if you look at the adequacy of bowel prep, if you look at the Boston Bowel Prep score, greater than 6 was achieved in 91% of patients in the 4-liter regime and 88% in the 6-liter regime, with no difference. P-value was 0.44. If you're looking at the adequacy of bowel preparation according to the US multi-society task force, then again, there was no difference between the two regimes, 91% in the 4-liter regime versus 85% in the 6-liter regime, with p-value of 0.24. If you look at the various detection rates, the adenoma detection rate was also similar between these two groups, 37% in the 4-liter group versus 32% in the 6-liter group, with p-value of 0.41. There was also no difference in detection of advanced adenomas, sessile serrated lesions, just polyps in general. And cecal intubation rate, also no difference between the two groups, with the achievement of 97% for the 4-liter group and 92% for the 6-liter group. Now looking at the tolerance to the bowel prep, I think this is not surprising, that there was a significant difference in how the patients were able to tolerate the bowel prep. The tolerance to bowel prep here is defined as being able to stick to the diet and able to drink, at least 80% of the bowel prep, 87% for the 4-liter regime and 73% for the 6-liter regime, with p-value of 0.03. When the patients were asked whether they were willing to repeat the same regime, patients answered yes in 91% of the 4-liter regime versus only 2/3 of patients who were taking the high-dose 6-liter regime, and this p-value was statistically significant. If you look at the tolerability components, there is a whole variety of reasons why people were, people found the bowel prep to be difficult. And although there was no difference really between the two groups, the things that our patients do complain about is numerous and very varied, which does confirm that these bowel preps are not easy to take, ranging from unpleasant taste, vomiting, cramps, chills. And so, it is not an easy thing to go through, I think, especially if you're taking a 6-liter regime. The limitation of the study is that only polyethylene glycol-based regimes were used in the study. Therefore, patients who failed PEG-based regimes before due to intolerance, usually from vomiting, may not benefit from a repeat polyethylene glycol-based regimes. The potential for selection bias is also quite significant in this study because there is a possibility that the patients who are non-adherent to bowel preps at index colonoscopy were not willing to undergo this, were not willing to be part of the study, and hence were excluded. Patients may also have adhered more strictly to their diet regime and bowel prep, knowing that they were enrolled in a clinical trial. So the main take-home point of this randomized trial is that split-dose 4-liter polyethylene glycol-based regime has a similar efficacy to 6-liter polyethylene glycol regime in patients with failed bowel preparation at index colonoscopy and should be considered in patients who have previously failed bowel preparation. Our next study is looking at the optimal age to stop endoscopic surveillance of patients with Barrett's esophagus based on sex and comorbidity. It was a cost-effective analysis published in Gastroenterology by authors Omid Vari et al. Current guidelines recommend surveillance for patients with non-dysplastic Barrett's esophagus, however, do not recommend an age for discontinuing surveillance. As with any surveillance program, the expected benefits diminish with increasing age and increasing comorbidity due to lower life expectancy, and therefore becomes difficult because you have to weigh the risk of having an endoscopy procedure versus the benefit that the patient will obtain by undergoing such a procedure. So the aim of the study was to determine the optimal age of last surveillance in patients with non-dysplastic Barrett's esophagus according to the level of comorbidity. So this was a cost-effective analysis. These authors developed 3 independent models to simulate patients diagnosed with non-dysplastic Barrett's esophagus, varying in age, gender, and comorbidity level. The comorbidity level was defined as mild, moderate, and severe, and this table below shows what mild, moderate, and severe comorbidity would entail. And basically, mild includes history of MI ulcer or rheumatologic disease. Moderate would include peripheral vascular disease, history of strokes, paralysis, diabetes, or a combination of the mild conditions that we mentioned before. And severe would include cirrhosis, AIDS, COPD, chronic hepatitis, chronic renal failure, dementia, chronic heart failure, or a combination of at least one moderate condition, except for diabetes, with any mild or moderate condition. These authors then calculated the incremental cost and quality adjusted life years gained from one additional endoscopic surveillance versus no surveillance at all. And the optimal age to stop surveillance was then defined and calculated as the age at which the incremental cost-effective ratio of one or more surveillance was just less than willingness to pay threshold of $100,000 per quality of life years. So this is a table that they calculated by age for the quality of life years gained versus the net cost for men. So as you can see, if you are 68 years old and have severe comorbidity level, the quality of life years gained is 28 at a net cost of $1.4 million. However, if you are 80 years old with severe comorbidity level, the quality of life gained for one additional surveillance for Barrett's is 4 years at a cost of $1.2 million. And what they then tried to do was to look at, okay, which age would it be cost effective for us to stop screening or performing surveillance for Barrett's esophagus? And they calculated the different ages for men and for women. So for patients with no comorbidity at all, the optimal age to stop surveillance was 81, and then 80 if you have mild comorbidity, 77 for moderate comorbidity, and 73 years if you have severe comorbidity. For women, slightly different, but you can see a pattern that the larger the number of your comorbidities or more severe the level of your comorbidity, the lower the age at which surveillance should be stopped. And as you can see, if you're a woman with no comorbidity, the recommended age to stop surveillance is 75 versus 73 for mild comorbidity level and moderate comorbidity level, and 69 years if you have severe comorbidity level. The main limitation of the study is that the authors were unable to apply the impact of patient comorbidity level of prognosis of cancer, and they used data derived from United States only. So the main take-home point of the study is that in addition to age, gender and comorbidity status of patients are important factors to inform the decision of when to discontinue surveillance of non-dysplastic Barrett's esophagus. The analysis in the study authors found that the optimal age for last surveillance of patients with non-dysplastic Barrett's esophagus was 75 years for women and 81 years for men. However, it is up to 6 years earlier for women and 8 years earlier for men if patients have severe comorbidities. So just for a quick recap, immediate oral feeding with low-fat solid diet, reduced length of stay and hospital costs in patients with mild to moderate acute pancreatitis compared to conventional oral feeding method of gradual diet advancement. Only vonoprozin-based triple therapy and reversed hybrid therapy achieved eradication rates of greater than 90%. Levofloxacin-based therapy achieved the highest eradication rates in Western countries. The split-dose 4-liter polyethylene glycol with bisacodyl regime had similar efficacy to the higher volume 6-liter polyethylene glycol regime in patients with failed bowel prep at index endoscopy, and should be considered in patients who have previously failed bowel preparation. In addition to age, gender and comorbidity status of patients are important factors to inform the decision of when to discontinue surveillance in non-dysplastic Barrett's esophagus. Analysis found that the optimal age for last surveillance of patients with non-dysplastic Barrett's esophagus was 75 years for women and 81 years for men. However, it's up to 6 years earlier for women and 8 years earlier for men if patients have severe comorbidities. So this concludes our journal club for August. Our next monthly GI journal club will be on September 1st, 2021, which is the first Wednesday of September. Thank you so much for joining us this morning. It's good to see everybody, and I hope you have a wonderful month. And please stay safe, everyone. Thank you.